But yeah, I guess those are some of my favorite things that I love to love, but also kind of love to hate.
Yeah.
Chiropractic medicine,
Same.
CrossFit, functional medicine, GLP-1s, and I guess hormone optimization specifically. Yeah, I mean, we've worked with chiropractors for quite some time, but we've actually never had one on the podcast.
Honored to be the first.
Yeah. For those who don't know, this is Luke Bergner, a local chiropractor. And we like to banter back and forth on social media quite a bit. Mm-hmm. But we actually agree on a whole lot of things. And we have a list of questions that we either have talked with you before about or that we have never spoken about. For example, I was watching the Gabby Lyon podcast. She's a friend as well. And she had a guest that said back pain is actually caused by bacteria in the spine, but not in an infection sort of way. So if you did a lumbar tap, there would not be any bacteria that grow out. And I had never heard of this. And I just don't, I guess the microbiome could have an effect, but like, what's the clinical takeaway from this? Where's the actionable item?
That's a good question. It's one that, I mean, all through school and all the research I've done, that I've never seen some sort of bacterial imbalance leading to spine issues or pain or anything like that. You know, you can see things where like a tuberculosis situation or some sort of bacteria like that can lead to spine pain, but that's a completely different thing. It sounds like we're talking about in terms of if you actually have back pain due to an imbalance of bacteria in your spine. I just don't know how that's measurable. It sounds like something where it's someone who can kind of sell something that sounds cool and sounds interesting and probably is a hot topic in a lot of different places. And so it's kind of something to just take advantage of from that position, in my opinion. If you can't take an objective look at something, I just don't know how you can posit it as the cause of someone's back pain. You're probably causing more problems for that person than you are helping them, honestly. So,
yeah. Sort of sending them on a wild goose chase.
Exactly. So yeah. Putting things in their head and then they're looking for an answer to something that's unanswerable. So,
yeah. Certainly if they don't have a clinically quantifiable bacterial infection.
Yeah.
As a functional medicine provider, one of the things. Yeah. I wouldn't want to treat them with antibiotics.
Yeah.
Certainly not IV, big gun, broad spectrum antibiotics.
Right. Well, I'd be curious too, what's their treatment protocol when it comes to that too, if there is a bacterial issue, because they should be referring out if that's the case. Because as a chiropractor, we are not qualified to treat a bacterial infection, whether it's causing back pain or foot pain or mental issues or whatever it may be. So,
have you referred out tuberculosis before? Can you say that? Because
I've never
an outbreak in Kansas City.
I have had one person that I sent for imaging on possible infection of some sort. They didn't have it. And so I ended up treating them and it actually went really well, but I was concerned based on just some general, they've had a recent fever and they've had recently traveled and things like that. So there was some concern on my end, but the imaging didn't show anything. So I thought, cool. And I thought, best to send them out and see if something's there. And if it is, then they're in the right place rather than with me. But no, never treated somebody or referred out for a legitimate spinal infection case as of yet. So, yeah.
Yeah, it does seem like that's a relatively rare thing, but back pain is very common. And we have spoken about this topic on the podcast before. But for people who are, worried about their back, there's almost this emotional, political thought when you say, well, you just need to go to a chiropractor.
Right.
But that means so many different things because a lot of people can be greatly helped by seeing a chiropractor for back pain. And yeah, you can argue causation, correlation. It obviously depends on the intervention, of which there are thousands. But how did that, we're all familiar with the history of chiropractic medicine, but how did it become such a dichotomy of people either really liking or really being against chiropractors for back pain?
Sure. I think as time has gone on, we've just generally been able to measure things better. And obviously in society, as we are able to do better research and things like that, there's not really anything in support of the classic chiropractic way, which, to kind of put it in a nutshell for people, it's adjusting people, relieves tension on the nervous system, which allows the whole body to improve because you're decreasing nervous system interference, right? So it's funny because this happens in school too. When you're in chiropractic school, there's basically two major camps, and some of us are stuck in the middle. I would consider myself that was stuck in the middle, leaned more towards the research side of things, now heavily lean more towards the research side of things, but I was searching at the time. And in school, you see the people who are what we'd call vitalistic chiropractors. And I think this is where it gets really political in the sense that these people very much are, it's an ideology for them more than anything because, and I think a big part of it is they have one weapon, which is the adjustment, which is what separates them from other providers or medicine or whatever it may be. And so the idea is that they need to defend that at all costs, because if they were to lose that, they were to lose their business, the profession, whatever it may be.
Yep.
And so then you have the other side who at times I think can also start to treat it as an ideology where it's like everything needs to be as opposite that as much as possible. And I think I agree more with that side more, but there is a degree of the vitalistic side that I do appreciate in the sense that like anecdotally, people do love it. And I think that does affect patient outcomes. And you have to consider that when you're treating somebody or talking to them about their experience with chiropractic, and find a way to be empathetic towards that, but also address that in a way that allows them to see the way that you do things as a way that you would consider more evidence-based to get them a long-term outcome.
Yeah, I think that's a great way to put it and sort of differentiate. There's, we talked about traditional versus functional medicine, and there's MDs and there's practitioners and PAs that are in both fields. And we kind of see ourselves as taking the evidence-based pieces that are good from both of those and kind of building them to the middle so they're not so siloed.
Right.
But in like the musculoskeletal system, which is where I think chiropractors in general have a lot of expertise.
Sure.
Probably even more than myself, because I do a lot of telemedicine, not a lot of hands-on or looking at people and how they move every single day. Where does your practice or even your education differentiate compared to a, physical therapist? Because I'll hear people sort of lump those in. They'll say, well, go see a chiro or a PT.
Sure.
So sort of what are the ways your practice can be more expansive, I suppose?
I guess, are you asking about my practice specifically or chiropractors as a whole?
Either or both.
Okay. I get to address both, I guess.
Sure.
For chiropractors as a whole, a lot of them will market that they do rehab. In my opinion, a lot of them aren't really doing that. They're kind of taking protocols that they found and just blanketing them towards other people so that they can slap that they do rehab on their website or whatever it may be. And in school, we do get some, I'm using the term rehab pretty broadly. I mean, it basically exercise-based therapy, I guess is a better way to put it. We get some education on that, but not a lot compared to manual therapy, obviously manipulation, diagnosis of red flags when it comes to the spine and central nervous system and things like that. And so I think that most chiropractors that you see that actually have a good understanding of exercise-based therapies are getting it from outside of school. And so someone like me, or I could name many others, we're spending, tens of thousands of dollars on extra education, seminars, books, whatever it may be. So you basically have to be just putting in a lot of hours. And where it differs from physical therapists is I do think physical therapists typically have a better understanding of exercise-based therapy when they first get out. I think that's actually shifting quite a bit for them, where a lot of them are starting to come over to the manual therapy side from what I'm seeing. But I still think it's the same thing. They kind of come out of school, from what I've seen, with a really basic understanding of how to treat certain conditions, and it's all been very formulated. So you hear the classic thing of like, oh, they have back pain, give them clamshells and glute bridges and bird dogs, and a lot of places are guilty of that. So I think that you'll even see physical therapists nowadays going outside of school to really get deeper into what's a true, evidence-based approach and helpful approach for the patient for exercise-based therapies that are out there. And if I can add to that a little bit, I think people get caught up in all these, what I would call the acronym-based exercise places. So there's, in chiropractic, big ones are DNS. Peter T is really into that. If you've heard of that one, MDT, that's the one where you just, press ups to death kind of thing. FRC is a really big one right now. If you've heard of like hip cars, shoulder cars, like that's a big FRC thing. And I see a lot of younger clinicians getting really myopic in one of these things versus another. And they're just like anything else. They have a flow chart and you just stick the person in the flow chart and you go from there. And I think whether you're a chiropractor or a physical therapist, where you run into problems there is that this person, it's not very goal oriented. It's at least to their goals. It's more towards your goals, which is to fit them into your system. So, I mean, to answer your original question, I don't think that there has to be so much of a difference if that person's putting in the effort outside of school, honestly. But if it is just something where they either have a DC degree with no extracurricular education beyond that, then from a baseline standpoint, the physical therapist blows the chiropractor away in terms of exercise-based therapy. I might get burned at the stake for that, but I think that's a fact. So,
sure.
Yeah.
It's really interesting. And then in your practice, and I know there's sort of a spectrum of chiropractors. Are people working with you for their whole body health, or is it usually for a specific complaint? I know some chiropractors, recommend a few supplements.
Sure.
Some recommend dozens of supplements,
Sure.
like patients. So kind of where does that fit in kind of what you're doing?
So the funny thing is I went to chiropractic school to do functional medicine. And I found out about halfway through that I would have been a horrible practitioner if that would have been the case. And me personally, if I recommend supplementation to somebody, it's something typically very basic. Like I know that they've had blood tests that show that they're low in vitamin D. So a vitamin D supplement would probably be good for you, or at least get out in the sun more, or whatever it may be. If they are a super active person and I know that their protein intake is really low and they're exercising a significant amount of time of the week and it's pretty high intensity, then sometimes I'll recommend at least a protein powder to supplement that, as well as a creatine situation. And I think that would help them at least recover quicker. But it's very basic stuff like that. And I'm never selling it outside of my office or inside my office to anyone. It's always just, here's a recommendation. You can get this at X place. If I think there's someone that could actually benefit from functional medicine, I think I always send them to someone else, right? Because that person's better equipped to do so than I am.
Is it always a nurse practitioner or medical doctor?
I haven't found a person yet. Lately, I've been trying to send them to you guys because I actually think you guys take a fair approach to things, where I think you would agree that in the functional medicine world, you can get on the super hardcore Western medicine side or the super hardcore, I guess, more Eastern influence functional medicine side, and both have, I would say, problems. And I definitely have a pretty good understanding of a lot of places that I know are just going to throw a basic supplement protocol at someone.
I know that you know the protocols.
I do.
I do. Functional medicine is supposed to be root cause medicine.
Sure.
But 99% of it is extremely cookie cutter.
100%.
And frankly, a lot of, nurse anesthetists or chiropractors, or they say, I want to be a functional medicine practitioner.
Sure.
What organization should I go to?
Sure.
And my advice for them is usually, frankly, the decision tree is, if you want to do that, first you have to do a primary care, like a broad spectrum family medicine or internal medicine or family nurse practitioner school, and do that first extremely well. And then everything else is supplementary to it.
Right. No, I couldn't agree more. And to get back to your question too, is I think that's what happens is a lot of chiropractors end up doing the functional medicine thing because they think they know a lot, when I would argue that most of their knowledge comes from Instagram or YouTube. And it's another situation of they just have a supplement protocol that sounds cool and they're throwing it at probably 90% of people, if not 100% of people. And then also to answer your question, in my office, so it's musculoskeletal care. So it's back pain, shoulder pain, hip pain, any sort of musculoskeletal issue that is inhibiting them from enjoying an activity that they like. There's obviously some preventative stuff, like some people just generally do want to get better mobility. If that's their genuine goal, then I can help them do that. I usually like to find something more in depth around that. Like, why do you want better mobility? But there's never been a case where I'm doing a whole body dietary supplementation approach with somebody, because I just don't think I'm well equipped to do that. And I would be lying to myself if I acted like I did.
So things like food sensitivities or allergies, there's not a specific muscle that you can poke that gets them better. Well, I've heard that things like spanking therapy. I don't know if you've seen the viral YouTube videos on this.
Is this real?
There's real thing. Yeah.
Oh, wow.
For listeners that are interested, they can look up spanking therapy. It's popular. I know there's a practitioner in Silver Lake in Los Angeles, California that does
I got to
this.
get a new niche. This sounds great.
But yeah, a lot of people also say that the spanking therapy has really helped their allergies or has really helped their impulse control. And I was thinking, well, maybe it's just because the glutes happen to be the muscle that's connected to the part of the brain where the allergy and immune response is. So I'm honestly not sure how that's any significantly different.
Sure. I would imagine some placebo effect to it. You know, I'm finding more and more as I'm in practice that people trusting you does have such a significant amount of degree of their outcome that they're going to get.
Yeah.
So I would imagine that the people you take that you're spanking them, if you
must trust them.
You could go down the street to the guy who's just rubbing peanut butter on their foreheads and telling them that it works, that if you put them on a graph together, their outcomes are probably going to be similar because it's just time and placebo taking care of the problem, in my opinion, versus we're stimulating glutes or stimulating some sort of forehead musculature or something like that. You know, I think a lot of that can be attributed to they trust this person, they've been looking for a long time, and it's something different that they've bought into from a mental standpoint. I can't prove that necessarily, but we have other research to show that things like that do play a big part into people's outcomes. So
yeah, the expectation effect is really potent. It's like you're speaking to, and it's kind of interesting with thinking about the like education and the benefits and the risks, like putting peanut butter on somebody's forehead. You mentioned food allergy. I think, well, what if that's a peanut allergy? Probably not great, but
wrong example.
In your education, I mean, you talk about the benefits of chiropractic and these adjustments, and I'm sort of interested in that aspect of it. Do they talk about like what can go wrong or people you shouldn't? Like you think of people you wouldn't prescribe a medication to, for example, or people that like this is a red flag symptom, that sort of thing. Is there a heavy emphasis on that in most programs? Yeah,
I would say most chiropractic programs are tailored towards figure out red flags for someone you shouldn't manipulate. And if they don't have them, go ahead and manipulate. I don't know why it's a 3.5-year program to do that. I don't think it needs to be that long. I don't think it's that complicated a medicine when it comes to that. But yeah, I would say that's typically what most chiropractic education is centered around, is reducing the liability and obviously giving someone help if they have a red flag. But part of that is about reducing liability. And then if it's okay, manipulating them. That is changing to a degree. And I think a lot of places, particularly a place like Logan University in St. Louis, is starting to really pick up on how exercise-based therapy and how soft tissue and stuff like that can really help to a more significant degree. But traditionally, that's 100% been the way that the education has been frameworked and structured. Yeah.
How do you learn when there's a rib out of place? Like maybe there's a rib in your foot that's out of place. Sometimes there's like a rib in, there's ribs everywhere.
Yeah.
There's ribs in your knees.
Sure.
Yeah. How do you learn that?
I can't lie. When someone comes into my office and tells me their rib's out of place, it's a little triggering. Because if your rib was legitimately out of place, I would probably send you out to someone else to have that taken care of, because I'm not.
It's like it's a fracture, right?
It is. Yeah. It would be a legitimate dislocation or a fracture or something to a bone that is, depending on the rib, can be vital to your respiratory function, right? So people say ribs out of place.
Don't they mean just a strain of a muscle that's nearby?
They should.
What it usually is?
They should. That's typically what's happening, is we have some sort of tissue injury near the rib head that is bothering it. Some schools do teach that ribs go out of place, from my understanding. I don't know how you would feel for that. I don't know how you would know that in any way, shape, or form.
You can't image for it.
You can't image for it. I mean, you could x-ray and see what's going on, but a lot of these places, they tell you to palpate. And if you feel stickiness or a lump or something like that, it can be a rib out of place kind of situation. which the thought process for them is to adjust it back into place, which my contention with that too would be like, if it's out of place, why would you want to try to manually jam it back in? Because if you miss, you could manually jam it somewhere else. So it just doesn't add up to me. So typically if people have a rib out of place, yes, it's probably some sort of, I say tissue injury, but that's again, a broad term. Something that is just irritating the tissue around that area that honestly, an adjustment can help it feel better. I mean, people at home, I mean, I'm sure you've asked your spouse or your significant other or whatever it may be to crack your back. I mean, just anecdotally, I think we can immediately say right now that it does. Yeah, it feels better, at least for a moment. So I think that's usually what people are feeling, is some degree of that. And the idea that your ribs would be out of place, if that was true, you need to go somewhere where they can actually help you with that. And that might be an ER situation.
So they're almost on accident doing some manual therapy on like an intercostal muscle strain, something like that. But then it gets this sort of umbrella term of, oh, they put my rib back in place.
Right. And it felt better, so it must have been true.
Sure, 100%. Yeah. So, and I mean, you can influence the joint, I'm sure. It doesn't all have to be necessarily muscle. I'm sure you can influence the joint, and there's some gapping going on there, which induces some sort of therapeutic effect. But yeah, just to go back to, I mean, the idea that your rib would be out of place is just too far-fetched. And especially in all these cases, most of these cases, a lot of these chiropractic offices, they do take x-rays, and you're probably not seeing that on the actual x-ray.
I agree with that.
Yeah. So why are we telling people that when your very own objective data doesn't even support that? So
how different is foam rolling from something like adjustment? Because both can provide some relief pretty quick.
This is a funny one because I just had a conversation with a friend who was he knows who he is. I love him. I'm not going to say his name out here, but he doesn't like people foam rolling. But I think that's because his only weapon is his adjustment. And so people can crack their back foam rolling. I think it has a very similar effect on someone as getting an actual adjustment from a chiropractor. And so in my opinion, yeah, foam rolling can be just as therapeutic in certain situations, probably in most situations.
Only for 35 plus though, is what I've heard at my CrossFit gym.
I guess I don't know.
We've heard that,
disagree
right?
with that.
After you're a certain age, you have to start foam rolling.
Yeah, foam rolling is interesting. A lot of people almost use it as like a crutch for everything too. And it's kind of like the same thing as an adjustment in terms of like the results that you get from it. You get a temporary increase in mobility. You get a temporary decrease in pain, both great things. It's what you do after that to take advantage of that moment that really makes the difference. And from my perspective, from chiropractic perspective, is the chiropractors see the foam rolling as a threat to their business.
Interesting.
And so it's the same thing with like self-adjusting. Like when people like crack their neck or whatever, they say you shouldn't do that because things could go horribly wrong and all these things.
Huberman says it's cool though, but just like this, which I think has some merit too.
Sure.
Like, I move my neck around from time to time during the day, and it does feel good.
It does feel good. Yeah, but it's the same thing. It's if they can do that on their own, then where does my business come into play? And my answer would be just, be a better clinician, solve people's problems in a different way. And that's what I've seen with foam rolling, at least in my world for the most part. I use foam rolling in my office. This morning, I just had a person with a hip issue, and we did some lateral hip compression with the foam roller, and it helped them feel better for a moment so we could get deeper into a position that I wanted them to get into. So
is foam rolling also the only way to get fascia back into the right place?
That is how fascia works.
Does it still work if someone's had a fasciotomy?
I'm not even sure I know what a fasciotomy is.
Yeah. Got one here. Can't see on the camera, but I had compartment syndrome.
Oh, okay. That makes
sense.
Okay. I get what you're saying.
Yep.
Okay. Yeah. Fascia doesn't work that way from my understanding.
It was not an elective fasciotomy. if that helps.
I thought that's what you meant. I was like, that's really interesting.
Not elective.
Yeah, fascia is so popular right now. Places like Human Garage and Functional Patterns are really big on fascia. And I just don't understand. Again, it's something that's not measurable. I mean, fascia is along for the ride, no matter what you're doing. I mean, if I'm moving my arm up and down, the fascia is along for the ride. And there's no way for me to measure that it's out of place or needs to be released or whatever it may be. And I think the mechanisms that people think that when they feel better from a fascial release or something like that, I think they're, again, something that's much more simple, I would say, than just, or yeah, I guess more simple than things that we already know, compared to we're actually taking fascia and manipulating it and changing the structure of it.
Mm-hmm.
And that's what's making them feel better. So again, I think fascial stuff is another, to a degree, sales gimmick that, again, sounds cool and it's new and it's got really interesting movements where you're doing all this crossbody symmetry stuff and it looks cool. And I think that's what draws people to it, but I don't necessarily think that it's legitimate in that sense where you have fascial dysfunction and that needs to be fixed.
Interesting. So it's like the new shiny object, and it's a word that people, maybe haven't heard, and then think, oh, this is the answer to my problems.
Right. And I guess I'm willing to be wrong there. There's a man named Antonio Stecco, I believe, that's doing a lot of research on this, and they have some interesting research that you can read on it. It's definitely not conclusive by any means. I'm interested to see where the fascial world goes in the future, because I actually think it's like growing in terms of people wanting that as part of their treatment regimen, whether that's right or wrong. So I'm interested to see where it goes. And that usually, when people are really into stuff, that introduces new research and objective data that we can get to look at it. And I'm interested to see where that goes. But as of now, both logically and based on what we actually have, I just don't see how we can know we're releasing flat fascia in any way, shape, or form. So
Interesting.
So heard it. If you are having your fascia manipulated, it's not a emergent fasciotomy. Probably not conclusive yet.
Yeah, and fascia is the peptide of the chiropractic world.
100%.
Yep.
Yeah.
Lots of research, lots of interest, lots of people being very aggressive, and some people that don't want to implement it whatsoever. And we certainly have, as people know, a very open mind, and are, I feel like it's very likely. In fact, I would say 99.99% chance that a lot of peptides that people are taking right now turn out to do very little benefit and maybe even have harm. And it's also 99.99% likely that a lot of peptides that people are taking right now turn out to have immense benefit when we finally do have large randomized controlled trials and have very little harm. So the problem is we have a pretty decent idea of which ones might be which.
Sure.
But we just don't have as much of the evidence like you're talking about that's also being studied in the fascial world. Sure. One thing that I've wondered with fascia, people have probably seen the viral picture of the 90-year-old muscle versus the 30-year-old muscle. I think it's a cross-section of an arm. And one has what's called high intramuscular fat content or triglyceride content. And they're the same size, but one is thick, lean, dry muscle with very little fat. And one is this kind of spongy material, and there's fat everywhere else. If someone has that high intramuscular fat content, does that make them a better candidate? Because I don't know if that's stretched the fascia or if there's, like more inflammation in that area. Do they respond differently to treatment?
So are we saying, I haven't seen this actually, so I'm really interested in it. Are we saying that the higher fat content people have, that's the side with more issue, I guess, than the other side?
Inflammation in the muscle. And it's often weaker, and it's more likely to have problems as well.
Sure. I mean, I guess I could see it in terms of just like the density of fascia versus the density of muscle kind of situation. And I mean, fascia and muscle do interact with each other. So, if maybe there's higher fat content, maybe there's some sort of communication imbalance there. I don't know. I mean, this is something I just don't know. I'm just kind of spitballing when it comes to it. So yeah, I'm not sure there.
We'll post a picture of this image where it has the two cross-sectional areas, but there is more and more research being done on intramuscular triglyceride and intramuscular fat content, which tends to increase over aging, but there's a whole bunch of other things that affect it.
And they even have some of these. It's really interesting because I think the one I'm thinking of is actually like a cross-section of somebody's thigh. Like if you're looking down their leg, you see the bone in the middle, and then you have like a 70-year-old triathlete, and theirs is, almost indistinguishable from the 30-year-old.
Sure.
Because they've maintained the function.
Yeah.
So that's sort of what I think is, it's like, it's a sign that you don't always have to follow that trajectory of like over time, your muscles just get fattier, you get insulin resistant.
Well, sure. I think if we know if your muscle mass is increased, that typically people have less problems later on in life when they have increased muscle mass to a degree. I mean, if you have the Ronnie Colemans of the world, that's different. But
Yeah.
For your average person who's just a generally active person, increased muscle mass is usually going to be a very good thing for them. So
Yeah, in general, if people are worried about being too bulky,
Mm-hmm.
then we can alleviate their fears. They just don't have the genetics. They will never be bulky,
Sure.
even if they tried. So,
What steroids do you recommend?
yeah, I guess it depends on the situation. I mean, likely more than half of adult males and females have taken some sort of synthetic steroid, even if it's their oral contraceptive.
Sure.
If someone's ever taken birth control, they've taken steroids, synthetic steroids. So it is interesting. But yeah, one other thought that I had, thinking of Ronnie Coleman, he has good abs, but does he still need to brace his core? So if you have a shredded six pack, does that make you less likely to have pelvic floor issues, more likely to have hernias and pelvic floor issues and prolapses, or what's the deal with core bracing? Because it seems like a lot of people who have good abs are not good at bracing.
Sure. I think bracing is typically more, I don't want to say complicated, but harder to actually do than people think. So when we want to brace, we want to create essentially 360 degrees of pressure. I mean, you can't make it perfect by any means, but what you are doing is you're trying to increase intra-abdominal pressure as best you can in a 360 degree way.
So it's like a box.
Yeah, a box
and
or
the
a
abs
cylinder.
Is just the front of it.
I tell people like a cylinder, like a Coke can or something like that. And the problem is often I see with people that they just don't know how to do that. And what they're really doing is just flexing their abs, their six-pack muscles. And so where that can create problems is they mostly do that when they're doing bending over activities, deadlifting, picking something up off the floor, whatever. Maybe you'll hear people all the time say, I never do that without bracing my core.
Mm-hmm.
The problem is if you don't actually know how to properly brace and you're just flexing your six-pack muscles, which is your rectus abdominis, the job of that muscle is to flex you forward. And so now you have a muscle trying to flex you forward while your back muscles are trying to lift you up.
Yeah.
It does create a shearing force that's just not comfortable. I recently made a post on Instagram about this, and I mean, you can do it yourself. You can literally just take your arm and go out like this. And then if you flex your bicep and hold that flexion and try to go out, like it's just not going to be as comfortable because you have two opposing forces going against each other. So the brace can be a very, very good thing, especially if you're like a power lifter or something like that. I would just say you need to take the time to properly learn how to brace, which can be done fairly quickly, but it is something where it's not going to be like brace your core and you're like, got it, nailed it kind of thing, So if you are somebody who does a significant amount of things like deadlifting or something like that, then I say, I mean, yeah, it might be worth your while to actually learn how to brace your core properly. If not, I tell most of my patients who aren't in that high level of activity to just let your core reflexively react. Like that's its job. It's going to do that, whether you consciously brace or not.
Yeah, I was trying to figure out why Maddie's so good at bracing because she's had 3 kids, and even when our last one was 2 months old, she went back to lifting lighter than usual, but still like almost like a 350-pound deadlift, and she obviously does not want a prolapse or anything like that. But she's actually not sure why she knows how to brace. And maybe it's because she's been lifting weights and training for, probably 15 plus years at this point, lifting lots of heavy weights. But she does not remember learning how to brace. But I think that it's because she's never really done specific ab training. She's done a lot of core training. She's done a lot of javelin and discus throwing. And she's done a lot of just powerlifting, Olympic lifting, all that. You have to use.
She would definitely know how to brace.
You have to know how to brace.
Yeah.
But it's like that. It's like the physician that's been practicing for a long time that has unconscious competence.
Yeah.
He or she kind of knows what they're doing, but could never teach anyone how to brace. So a newbie might come up and ask her, hey, how do you brace? And might know the basics like, well, it's not just your abs. Like make sure you're also kind of like pushing out to the side. But past that, that is probably something that a lot more trainers should teach.
Yeah, I think so.
It's interesting. And on the other side of that coin, so we're talking about, like you said, someone's crunching their abs, kind of trying to be intentional, but unintentionally like messing with their biomechanics and making their job harder.
Sure.
On the opposite side of that, people who sort of unintentionally are not firing the correct muscles.
Mhm.
So you hear this a lot. People, will have some sort of issue they're compensating for, or I think just with people being sedentary, like if you're not using those muscles, they're not used to firing. And
Right.
you hear people talking about like getting the muscle to wake up again or getting
Mhm.
it to fire again. And
Mhm.
there's legitimate, circumstances where this is the case. Like myself, I had a pec repair from a tear 2 months ago.
Sure.
And I'm still trying to get my pec to wake up.
Sure.
Right? It activates, but it's definitely not where it needs to be.
Right.
So is there like a term for that? And do you see that in a more sedentary population where they are having a harder time getting their glutes to fire or, other muscles that they're just not routinely using or not using properly?
Right. I actually don't know what the proper term, I guess, is for that is. Hopefully that's not a reflection of me as a clinician. But from what I see, most of the time, if somebody says, I just can't get my glutes to fire, most of the time they're not doing anything in their regular life that is actually requiring them to do that so much. Or they do have a history of that situation, and now they're trying to do something where they're firing their glutes more, and they're just not developed that way. They're just not conditioned in that way. I do think there are ways that you can get people to, I'm just going to stick with glutes as an example. I think this is the most popular one for this, where you can get people to feel it more.
Like spanking therapy.
Like spanking therapy.
Oh,
I'm 100% doing this. I mean, I can't wait.
Yeah.
So there are ways that you can get people to feel things in different ways. Playing with angles is a good way that I do it. Just putting them at a completely different biomechanical space than they're used to, and having to find a way to fire a muscle to keep them upright or to move laterally or whatever it may be. Sometimes when you make that mind to muscle connection for them, it kind of just like cascades into everything else they're doing when it comes to that.
That's what I call it too, by the way. Mind to muscle connection.
Yeah, sure.
Yeah.
It's great. And so yeah, when it comes down to it though, I think most of the time it's just people aren't, their life just hasn't been requiring them to use it so much. I mean, a lot of these people are just people that, are sitting down for much of the day. I mean, as if we sat here for 8 hours, our glutes are nice and quiet for most of the time. And that's a significant portion of your waking hours. So
my glutes hurt, not because of the CrossFit competition I did Friday and Saturday, but because they brought out this giant box. I'll send Cameron a picture of me sliding over that thing, almost 40 times. Just direct trauma. But yeah, surprisingly, not too hard on the glutes. I'm interested, are you in the camp that is for or against specifically trying to squeeze your glutes at the top of a deadlift?
I'm, again, probably against it. I'm against forced muscle contraction during an actual activity. I think people really underestimate how smart our bodies are in terms of engaging muscles when they need them. I actually recently had a patient the other day who just was talking about how he can't get his glutes to fire. He was very strong, and he kept telling me about, he was doing these 25-pound RDLs and kind of things. And I'm like, you can't get your glutes to fire because the weight's just not heavy enough. You don't need it. So we increased the weight and the glutes fired. So sometimes it's what's the capacity that you're asking your glutes to take on? Because if they don't need to, sometimes they just won't. Could I make them, I guess, fire with that 25-pound dumbbell? Yeah. Do I think that it's required? Not necessarily. But I am not a fan of the force this muscle to do this. I say just do the movement and let the muscle do what it's supposed to do.
I like that.
Yeah.
What about calves and Achilles? Because as I think I mentioned to you the other week, I went through a long period of time with difficulties, Achilles tendonitis, pretty bad.
Yeah. Tendonitis stuff is tough. I think that's probably the biggest misconception in terms of recovery timeline for people that come into my office. And what I've read in the research is 12 weeks is the absolute minimum you need to reach a pretty good threshold of where you can get back to normal activity. I think it's longer than that based on my personal anecdotal evidence. Tendons just don't get great blood flow. They just don't. And increased blood flow is huge for healing times. And so when it comes to a tendonitis situation, a lot of people tend to think that, okay, let's take the Achilles tendonitis, for example. So plantar flexion, dorsiflexion. So foot going up, foot going down is what gets the Achilles to engage, right? And so a lot of people take a lot of concentric activity. So that's the muscle going through its ranges of motion to try to fix it. When if you're doing that right off the bat of a serious I shouldn't say serious, of a real tendonitis case, you're probably just going to make it angrier. What we see over and over again is that putting the tendon under load progressively, particularly with like isometrics, and then just progressively increasing the range of motion that it's going through around that time is the way to actually get really good tendonitis results. And I'm not I typically don't like to tell people not to do something when it comes to like an Achilles tendonitis or something like that. If they're used to running 12 miles 3 times a week, that is a situation where it's like, we probably need to bring it down, because it is a legitimately aggravating factor it's just not going to get better if you keep trying to push through this. So tendonitis is tough. And I think the toughest part of it is overcoming the patient's perception of how much effort and time it actually takes to solve it for good.
Yeah, it certainly took a little while. It would get better, and then I would do something that aggravated it, and then it would get a little worse.
Yeah.
But it's been back at 100% for quite some time. I think in my case, one of the reasons why it took a while is Achilles tendonitis is one of the types of tendonitis that PRP and BPC 157 tend to not work very well for. So I actually had to put in the time and the work and do the actual rehab, if that makes sense.
Isn't it?
It wasn't just the extra collagen protein.
Probably not the extra collagen protein. That probably didn't help.
Is there validity to that? Because I have heard before that taking collagen, particularly like 30 minutes before any sort of activity when you have a tendonitis, can be beneficial. I don't know if that's true, but I've heard that before.
Yeah. Not that I know of 30 minutes before, but there are a few relatively well-controlled studies to where both tendon springiness and thickness can be improved.
Okay.
But it doesn't account for the, because when you're talking about collagen, it's just the amino acid breakdown of the few collagen peptides that there is. And perhaps type 2 collagen is better than type 1 and type 3. But I also think it's pretty likely that if you have someone that's, for example, a vegan, then collagen is probably going to be particularly efficacious with them. Whereas if you have someone that eats a huge amount of meat on the bone, I would probably be in that camp. And maybe it's not as helpful, but it doesn't hurt. So I take it anyway.
Yeah, it's interesting. I've seen, there's 2 papers I'm familiar with where you get a thicker tendon, not just from taking collagen and doing nothing. You're doing some sort of intentional exercise. You're doing like an Achilles rehab protocol. You're an active soccer player and your patellar tendon's getting thicker faster than if you weren't taking the collagen. And when I've seen people sort of debunk it, they're looking at studies that look at markers of collagen formation. Okay. So they're like either taking a biopsy or looking at blood markers, and they're saying, well, these markers didn't increase, so collagen protein doesn't work. But if you're looking at like the end result, a thicker, stronger tendon would seem to be the outcome that would sort of supersede whatever the blood level is telling you or what the biopsy is perhaps telling you.
Sure.
So that's sort of my take on it. Now, I suppose you could answer like, is a thicker tendon always better? I can't think of a scenario where that would be maladaptive, but maybe there is one.
Not one I can think of. Sounds like I need to add collagen into my supplement protocol recommendations for tendonitis cases.
Yeah, it certainly doesn't hurt. And again, it's probably not like, in someone like me, I don't think it makes a massive difference, partly just because I'm eating a huge amounts of those same amino acids and even collagen in the bone broth that Maddie frequently makes, and that I just eat a lot of meat off the bone, Nepal style. It's where I'm like eating the cartilage and all the tissue. I don't want to waste any of it.
Sure.
And you can kind of teach yourself to like this too. It's kind of like where I think the next version, it's in vogue to eat organ meat. So I think it's going to soon be popular to eat everything off the bone, nose to tail, if you will.
Be able to get your collagen pills that are less efficacious than just the raw powder before you know it.
Yeah.
Be a lot of pills.
Yeah, be a lot of them. But and part of it's just being a good steward. But that's probably not the most surprising thing that people have thought about. I mean, the three of us are certainly not anti-supplement. No. But what are some of the surprising things from the chiropractic world and some of the surprising supplements that you have seen recommended?
Sure. I mean, right off the bat, I think particularly in the COVID era, the ivermectin was quite often recommended as a supplement
From chiropractors?
from chiropractors.
Oh, interesting.
They couldn't provide it. I think some were providing it in some not so ethical ways from what I've heard. But that's the first one that I think of, is that it was pretty widely recommended in the chiropractic world. The question was most surprising thing I've seen in the world of chiropractic.
Yeah, it doesn't have to be a supplement.
It could be good or bad.
Okay,
Yeah.
sure. The most surprising thing I've seen in the chiropractic world, I really still think that the most surprising thing I've seen is just that this nervous system based approach. I really don't understand how so many people have bought into it. I don't know if you guys have seen what like a Merrick chart is by chance. Mm-hmm. So if you were to go into every chiropractic office in America or across the world right now, honestly, I bet at least half of them, you would see what's called a Merrick chart.
This is what muscle you poke or adjust for that area of the brain?
Yes.
Yeah.
So it's like you would adjust. I don't know my Merrick charts, so if I get this wrong, don't sue me. Let's say you adjust T12. T12 goes the nervous system, or the nervous system equal to T12 is the kidney. So if somebody has kidney issues, you adjust T12, and T12 solves kidney issues if they have like a pyelonephritis or something. I don't know. You know,
dialysis.
Interesting.
Sure. Like it's things like this that it's like I and there's so many chiropractors that still ascribe to this ideology, I guess. I can't think of a better word for it. And there's just I'm the kind of guy that, like, I am pro research, obviously, but I do think you have to take some of it with a grain of salt and recognize that there is anecdotal evidence to things, and there's things that we just don't know. But when you have zero evidence for it, that's a pretty compelling case for it not being true. And it's still very heavily a part of the chiropractic world. And it's what a lot of patients believe in as well. I have patients that have decided that we're not a good fit together because that's what they believe, and they just can't get on board with the way that I do things, which is fine. We talk about it empathetically and fairly, and there's no concerns or anything like from that standpoint, but it is just a situation where we're not the right fit for each other. And it's still probably the most surprising thing to me, just because we have so much evidence against it. But back to your, I think, initial, maybe second question of just the political aspect of this chiropractic world that I live in, it's very hard to let go of because it's almost intertwined with their being at this point. So,
yeah, it is very interesting. And from a personality standpoint and probably even a lifestyle standpoint, we certainly align with a lot of chiropractors. And in fact, there's kind of a running joke that wherever I go, whether it's my kids' wilderness play school or whether it's church or whatever else, everyone, for whatever reason, they always think I'm a chiropractor. And of course, I take it as a compliment. I think it's because proportionally more chiropractors are in good shape than medical doctors.
Sure.
Or maybe there's a different reason. Maybe there's something a little woo-woo and crazy about me too. But
you're saying chiropractors are woo-woo and crazy?
Some of them. Whether you're talking about a chiropractor or a functional medicine doctor or midwife, people say, are you the witchy kind or the Christian kind, if that makes sense. And people know I'm more of the Christian kind, I guess, but I don't know if either one of it's not necessarily good or bad. There's good practitioners that are in the woo-woo camp as well.
Sure.
It's like you said, it's all about how you explain the treatment or intervention or even diagnostic assessment to the patient and the strengths and limitations of that.
Yeah. And we touched on expectation earlier, but, there's patients that get better. Part of that's in the follow through. So you probably tell them do some things when you're not in my office. You're not going to get somebody better in 2 or 3 hours a week.
Sure.
But aside from let's say adherence to the prescribed exercises, how do you set apart, when you're thinking about a patient who's going to get better or who you've seen get better versus someone who is probably not going to get better or you've seen sort of fail to improve?
Sure. I do tell my patients on the front end, if they're going to work with me, that I have requirements of you communicate with me frequently. So I have an app that I do my exercise programs with, and you can speak with me directly through the app. And I do ask my patients to check in with me as much as possible. Most of the time that's me checking in with them, and they do answer the vast majority of the time. But to me, I really can't help you to the best of my ability if I only know what's going on one time a week for an hour. That's how long my appointments are. And I'm usually seeing somebody one time a week. Sometimes I have some people that are 2 times a week if it really is like an acute situation where they could use a little more hands-on help. And, but that's one thing I have people do. And the second thing I do ask them to be committed to the home programming, because I think that my goal with anyone is that they become individualistic by the time that they're at the end of a program with me, and they have all the tools that they need, that if this thing were to flare up again, which is the nature of something particularly like low back pain, that they have things that they can look back on that are going to help them. And so the things that I've seen that distinguishes a patient from one that gets better from ones that doesn't is they have clear expectations. So that's basically a prognosis of how long is this going to take? What do you need to do? What's required on your end? What's required on my end? What can you expect during this timeline? 2 is that they understand that there will be flare-ups. So with almost anything musculoskeletal related, you're going to have a flare-up during the recovery process. And far too often I see people have a flare-up and they quit whatever plan that they are on, or they move on from one thing to the next over and over and over again. So it's kind of like hopping around from dry needling to massage to fascial release to whatever it may be. And usually when you're trying to recover from an injury or pain, doing that causes more confusion than actual good outcomes. So usually I want patients to understand that there's probably going to be a situation at some point during this time where you're going to have a flare up, and as long as we're still on the same trajectory upwards, and we can get right back to that. It's just natural of it. So expectations around both timeline, expectations around the natural progression of what's going on here. And then the third thing I would say is I just see people really overestimate what can be done in a really quick time frame. So I get a lot of people that want something that's going to be done in 2 to 3 weeks, and it kind of builds off the first 2. But it's something where they give up and they move to the next rung of what you would do, which typically would be like an injection or a steroid or something like that, which those are necessary in some cases. And I have referred people out for that. And these are also the people that go to a surgery consultation far too soon because they say, a chiropractic or PT failed me or whatever it may be, and they only put, 2 weeks into it kind of thing. I think there's an old saying that the most common, like the average patient visit number for PT and chiro, like the most common one is 1. And so I think that if you're a clinician, it's really important that people have those expectations. And when they understand that and they're bought in to that, they get amazing outcomes. They really do. And when they understand that and it doesn't align with what they want, at least you gave them the information that they needed to understand what was required. And if it still didn't fit with them, then, you did all that you could. A lot of clinicians get in trouble and when they succumb, I guess, to the patient's demands more so than what they know to be true. And that's when patients don't get as great an outcome, in my opinion. And so it's really on the clinician to give them the right education and the right expectations around what to expect for their problem.
I think it's interesting that insurance companies also somewhat dictate this.
Sure.
Because some people go through, therapy or rehab literally just to satisfy that requirement before they get a surgery.
Right.
Yeah, they don't really put their full effort into it. But on the other hand, a lot of people put extreme efforts into it and are very closed off to surgery or procedural options.
Sure.
Earlier when we were chatting, you mentioned a GHD, which I believe is a glute ham developer for people who don't know.
Yeah.
But in the context of flipping around and using it to do ab exercises, which can be particularly brutal. But I've kind of identified 3 things that people start doing functional fitness and they tend to get injured on. And yes, deadlifts is one of them.
Sure.
We've mentioned that as well. The GHD sit-ups is what I call them, is the other one. And one of our good friends actually injured his back doing a GHD. Started CrossFit and then, doing some heavy GHDs. And the people that injure themselves with the GHDs are very frequently like very heavy individuals,
Sure.
usually very strong individuals
Sure.
as well, top heavy. So more shearing force on the spine.
Right.
And then for whatever reason, snatches, especially
Mm-hmm.
heavier, higher rep snatches.
It's a failure.
Yeah, it's a failure, especially. But, you know, people on the podcast have kind of heard what I say, but there's obviously merit to doing functional fitness
Sure.
and to, like, you know, try to, like, the whole point of this is to be able to, at least for a lot of people, including myself, is because you want to do more things when you're old, not less things.
Right.
What advice can you give people? You know, like, let's say you were talking to our friend before he got into his functional fitness journey. Other than just be careful on those 3 exercises, what can people be on the lookout for?
I typically tell people, because I have a lot of CrossFit athletes and I frequent a CrossFit gym too as well. And I think the competitive culture of it can at times become a bit problematic. But what I tell people typically is we need to get clear on what your actual capacity is. Because if you've never done a GHD sit-up, that's a lot, like you said, a lot of shearing force. It's high velocity. If you're someone who, like you said, is very thick, strong, maybe you're even like a power lifter, you're not used to high velocity movements at that range of motion. You're used to picking something off the ground that's not an incredible extension of the spine. So it's really, what is your body prepared for, right? And so most people aren't prepared to start going and doing high velocity, high rep GHD sit-ups, or same thing, high rep snatches, or whatever it may be. It's literally a movement that your body's just not used to. So what I tell people typically is, all right, you want to do a snatch, right? This is where you're at now. Your shoulder mobility is not very good, especially if it's under load.
Yep.
You don't really know how to get from a shrug to an overhead in any way, shape, or form. So we need to, snatch is the goal. Great goal. Love the goal. We need to break this down in a progression that makes sense so that you're able to do this snatch at the level that you want to do it in a way that's going to be safe for you, so that you don't quit CrossFit in a month when you, 1, can't do the snatch, and 2, you got hurt because of it. I would rather you have a 3-month span where you feel like you can't do the snatch, but you're getting better at it, and then get to the point where you can, and you can do it safely, and then you can start increasing the reps, things like that. So there's usually pretty simple ways to do that. I mean, a lot of ways that I do that is decreasing the range of motion, decreasing the tempo, or doing isometrics, whatever it may be, and then just gradually progressing those to more range of motion, more reps, more weight, whatever it may be. It doesn't need to be quite so complicated as some people make it, I guess. But it is something where it's almost like you need to put your ego in check. You know, just because you saw somebody that does a snatch and you're like, I'm probably as strong as them. It's like, well, they've been doing that movement for 6 months and they're pretty good at it now, and their body's prepared for it. So you may be stronger than them in some semblance, but
Yeah.
with this specific movement, it's different.
A lot of these people that I see get injured bench upwards of 350, 400 pounds.
Sure.
So they're extremely strong. Squat 500 pounds
Sure.
plus. So, you know, they certainly have that on almost all CrossFitters. But I tend to tell, I don't know what your timeline is, but I tend to tell them any exercise that's new, even if it's something that's seemingly simple, like a toes to bar, which is where you hang from a bar and then you can kind of push back with your lats a little bit and touch it with your toes. Even something like that, just go nice and easy and ride the brakes for 6 months, which seems like a long time.
Yeah. I think that's a fair amount of time. And I would say the CrossFit gym I go to, they do pretty well at this. So I appreciate them. Again, it's people underestimating how much time it takes to really get used to something like that. I mean, the time it takes to develop your lats in a toes to bar, the time it takes to get used to doing the swing that is required for a toes to bar. It's probably, again, not a movement that you're used to. And if you start it too early, you're probably going to be either really jerky with it. And again, that's a high velocity movement that your body's just not prepared for, or whatever it may be. So 6 months is a pretty darn good timeline, in my opinion. If it was up to me in my practice, 3 months is usually where I go with people. That's also me trying to bridge the gap of what they expect versus what I think is actually required in a lot of ways. If it was up to me, I'd probably go with longer care plans even than that. my goal, honestly, again, like I said, is that we get you through the 3 months and you have enough information to supplement the rest of the way. But again, it's a situation where it's like, yeah, are you willing to swallow your pride and do knees to chest before you do toes to bar, and then learn how to swing without doing any sort of knees or toes to anything, and then start putting it together. It's the same as we just talked about with the snatch. We're just breaking it down into less range of motion, less load, and we're working our way up.
Or even strict toes to bar, which I would say is a lower risk activity. A lot of these individuals that are starting, I even try to avoid, like the only reason why I enjoy a kipping or butterfly pull-up is for competition purposes only. But as much as possible, I do strict pull-ups. You're not going to be able to put in as high of a score in whatever scoring app you have. And I do think that a lot of people get caught up in that. A lot of people who are not very competitive, maybe that does help them. And it's one of these things where if you're not as strong, then you are probably safer to push things harder, as long as, like, you know, your relative strength to mobility to flexibility ratios are just going to be better. Because these issues, I usually see people who are either really strong or they're just especially not mobile or flexible or at baseline athleticism, if that makes sense.
Yeah, that does make sense. I don't think you can say it enough of like recognizing what life has been requiring of you. I mean, I had a patient once who they wanted to deadlift more weight, and every time they'd go back, they'd get low back pain. And they had been to 2 physical therapists who were both MDT practitioners, which is McKinsey, which I've taken McKinsey A and B, honestly, and it does have, there's great things about it.
Isn't that for radiculopathies?
It's more intended towards radiculopathies. A good way I see people use it, and I use it in my practice, is to just decrease pain in a really quick way. So a lot of people are just so used to flexing forward over and over again, their back's kind of crying for some sort of extension. So you can kind of use that to almost, honestly, I'm not sure how that works necessarily, but it's worked enough in my practice where I can get their pain down. But, you know, back to this person, they wanted to do the deadlifting, and their back would just hurt after their successful physical therapy situation. It's like, well, the protocol that you were doing was 3 by 25 sets of press ups with a, you know, bed sheet around you to give you more load. You're trying to deadlift 350 pounds. You're doing a high volume, low load exercise for a month and a half. And then you're going to a low volume, high load exercise because you want to lift more weight. Your body's not ready for it. Like, yeah, we got your pain down and it was seemingly a successful outcome. But again, this is where I think the way I do things, which we would call goal-oriented rehab, is where it comes into play. This person wanted to deadlift. The rehab should have looked more like doing something that was low volume, higher load, and built up to that, rather than we're just going to do press-ups because they're working and we're just going to crank through those like crazy. So that's a situation where, yeah, it's not reflecting what that person's life is asking them to do or what their goal movement is. And I think so many people don't recognize that at the beginning of what are the actual intricacies of the movement or the goal that you want to do.
Yeah. And it sounds like there's a graphic on your Instagram that we saw this morning. We really like sort of this cycle people get into where they, like you said, have a unsuccessful rehab program, and then they sort of bounce back and forth between pain and then trying a new intervention. So, you know, like you talked about, you know, maybe they're doing, you know, acupuncture, PT, random stuff they heard on YouTube or TikTok. I'm sure you hear all kinds of things, people come in and tell you like, oh, I heard this on TikTok. What do you think about that? Yeah. It's kind of alarming. But in any case, I thought it was a really good graphic, and we can put that up in the podcast and link to it in the show notes. But, you know, how do you break that cycle for somebody? So in this case, you know, you just built out I don't know, maybe a more intelligently designed rehab program. It's like, okay, you're thinking of the goal and then building a more logical path there.
Right.
Whereas it sounds like the other practitioners were just thinking of, okay, let's relieve the pain, and then you can go back to usual activities, that sort of thing.
I think, and I did this, it's funny I say early on of being a practitioner, I've only been a practitioner for a year. very early on of being a practitioner is I underestimated how important the interview process is and the verbal assessment with someone, and recognizing where their relationship almost to pain and how they attack getting rid of it. And so I often use that specific illustration with people. I'll post it up on my computer and I'll show them, oh, look, this is you right now. You are this person who rests, you get deconditioned because you avoid, you try to go back into it. Now that you're deconditioned, you're not ready for it. And so you get pain again. So you rest and you avoid and you get deconditioned and you get pain. And usually if you can help someone to recognize that, it's quite often a big game changer in their recovery because they did not understand their psychological makeup around how they experience pain. On the flip side, you have the people who are just the people who just push through, and they're kind of becoming in the same camp too. It's like you just push through and then you dip really far because you get a serious injury. You get better and you just recondition so fast that it's just too fast kind of thing. And so it's always good to have those kind of illustrations for people, because once they understand that, they understand why they haven't been getting better for so long. And it's really that the rehab approach for them, or the treatment approach, or whatever it may be, did not reflect the kind of person that they were when they first started trying to attack this problem, whether they're a person that takes a very approach heavy way or a very avoidance heavy way. Both have cons that you definitely want to address and figure out a way that you can make that clear to them so that they can see that there is a way out of it that isn't just me getting poked and prodded and doing exercise. There's actually a psychological piece of this that has to be addressed as well.
Speaking of way out, we have a protocol at the practice. We call it our trap bar deadlift protocol.
Okay.
And there's obviously been studies between what's called the trap bar or hex bar and a regular barbell. And it activates slightly different muscles when you lift. And
I have one in my practice. It's great.
Yeah. And we're obviously open to changing our minds, but at the very bare minimum, for people that don't, maybe they don't have a serious enough complaint, they just don't feel great when they deadlift, so they avoid it. But perhaps they want to learn how to do that. A lot of times we just have them start with literally just the trap bar, or maybe 10-pound plates on each side. And even the high handles. I'm not against the high handles, like less range of motion.
Yeah,
it's a start.
It's fantastic.
And then you slowly work your way up. And, but people don't, a lot of times they don't want to go all the way back to that. But like you said, there's that hole. They're totally fine doing the body weight. But then when you add in a barbell or something that they would see in a gym, something goes off in their head that they just need to add as much weight as possible.
100%.
Yeah.
I'm that guy.
I guess other than just writing a smartly designed 3-month or 6-month rehab plan, do you have like a piece of actionable advice of how people can either track that or log that, or just not go down the slippery slope of adding too much too fast?
Right. I usually have people think back on injuries that they've had and what has their been approach to that injury, and really think on it. And so like I was saying to James, one of the things you're going to see often during that time, if you go back, is you're going to recognize if you're a attack it hard person or if you're a complete avoidance person. And that's always a good place to start, because those extremes lead to problems, right? And so if you can figure out where you usually are on that spectrum, you can typically find a step above or below that, or whatever it may be, to get a better and more tolerable entry point. So it's just another situation where you're recognizing, look back on these injuries. How have you attacked them in the past? Was it successful? Was it legitimately successful? And if you're having the same problem again, it probably wasn't so successful. And if it wasn't successful, recognize which of those ends of the spectrum that you're on and how you can adjust it from there. I will say that it's difficult, because recognition's one thing, knowing how to navigate a progression that makes sense for you is another. And when you're doing it on your own, ego definitely comes into play, because no one overestimates their capabilities more than their own person. And especially if, like you were just talking about, somebody that just wants to put more weight on the bar. I am that person, so I need someone to kind of keep me in check. Or you can be the person that's just so scared to put weight on the bar that you need somebody to be like, hey, add 10 pounds, let's see what happens, knowing that it's going to be fine kind of situation. So for people at home, actionable advice, recognize where you are on that spectrum, and least then you have a start of where you can go from there and try to piece something together that makes more sense, whether you need to progress upwards or whether you need to regress downwards. There's no shame in either one, because I promise you'll get to where you want to go if you take the time and effort to actually plan something out and get it there.
Do you use active and or passive hanging, like hanging from a bar or rings in your protocols?
Yeah. So I do that with shoulder pain people a lot. It depends on how far on the pain spectrum that they are. 4 out of 10 pain or less is one I really like, where it's like, I just have this nagging shoulder pain when I go overhead, and it never gets above a 4, and it doesn't really get worse as I'm doing things, but it just hovers around this 3 situation. I'll have them sit in a hang for a while. And you can change that too. You can have them hang while their feet are on a box. You can have them hang where their feet are on a box at a different height so that it's more load. And then you can have them obviously go to a point where they're literally just hanging from there. But it's another simple progression where they're used to sitting in a position where they're overhead and just getting used to being there under more and more load as time goes on. And it can be really helpful. And I do that a lot with my CrossFit athletes in particular, where maybe they've gotten fear around hanging from the bar at this point, and just the act of getting them back under a bar in a controlled setting where they feel safe about it can have huge effects, because they've done something that they didn't think they were going to do maybe ever again, or at least for a while.
I've heard that CrossFit, and I don't know where this original quote is attributed to, but one of the best things it did is put bars or barbells in people's hands.
I like it.
But also one of the worst things it did was put bars or barbells in people's hands.
Makes sense.
What do you think about that?
It does make sense. It's based on everything we're talking about. I mean, putting a barbell in somebody's hands is a huge thing, because it's not a secret that getting stronger and doing functional movements is going to improve your life in some way, shape, or form. But it's just like what we've been talking about is, what's this person's psychological makeup? Are they going to throw a bunch of weight on the bar and hurt themselves? That's obviously the biggest risk that comes down to it. And a lot of us are very competitive. I myself am very competitive, and I had a CrossFit injury early on because of that. And, it is, I guess, a catch-22 in that. I would rather see more people get under the bar. I think there are really good coaches out there who do some sort of onboarding, on-ramping process where they are laying out the risks to people and giving them some semblance of a progression that makes sense. And I think that should be required in at least every CrossFit gym, maybe every gym in general. I don't know how that would work with like a Planet Fitness or something like that, but it would be good, because then that person would at least have more confidence in both not getting injured / being able to get to the results that they want for themselves.
Yeah. It's interesting to look at the CrossFit mentality when it comes to injury. For example, I have never been injured doing CrossFit. I've had several
You're
tweaks.
a unicorn.
I've had a lot of tweaks, which require some intervention.
Sure.
But most people would consider it an injury. A lot of times they just don't. They say, I'm not injured. It's just something is a little bit messed up.
I get that all the time. Yeah.
Yeah. The other interesting mentality is, and I haven't found a way to rectify this yet, but whenever you put a CrossFitter on a bar and tell them to hang there, they just automatically start kipping and swinging, and there's nothing that you can do about it. But in all seriousness, I do think that, when you look at a CrossFit gym, a lot of people are very good at knowing where their limits are. It's kind of like being a deer on the most popular game preserve. Like they know how to avoid the hunters. Sure. They know how to avoid the injuries because they have been there and done that maybe for 10 years. But that's a skill that takes time to develop.
100%.
And they also have like a pretty, and I know a lot of them would disagree with what I'm about to say, but they have a pretty narrow amount of approved movements.
Sure.
So like, they obviously do barbell cycling and GHD sit-ups. They do kettlebell stuff. And they don't add in new things that often. And people are probably going to type in, we added in crossover jump ropes last year. It's like, yeah, obviously they add in some things, but they're often not very fitness related. So for people that want to take up that positive mindset. Dr. Wheeler, who's a back pain sports medicine doc, talks about this sometime too, but there's definitely a lot of mindset or mentality that I think we can all teach people to some degree, that it's okay to view something as not a catastrophic injury, even if it is a significant injury.
Sure. No, I think that should be the way it goes, because I think for a long time we've almost been on the opposite spectrum, where we're kind of convincing people that it is a catastrophic injury and that, avoidance is the answer, or that you need to kind of skip the step of PT or chiro or some sort of conservative musculoskeletal care and you need to go straight to orthopedic surgeon or whatever it may be.
One of my good friends who's a nurse practitioner does CrossFit. And this individual was at an orthopedic doc.
Sure.
I believe for knee pain.
Okay.
And at some point in the visit, she mentioned that this certain CrossFit activity injured it. And the orthopedic surgeon says, scribe, he had a scribe, write that down, CrossFit, put that in the chart.
It's the demon.
I thought that's wild. Like, does that significantly change the diagnosis, or?
You can code for 99215 if CrossFit's in the diagnosis.
Yeah.
I have somewhat of a big problem with that, I guess, because it really matters what someone loves to do in life. And if someone loves to do CrossFit, like, you shouldn't just willy-nilly take that away from them because you think it's the cause of all their injuries, or whatever it may be.
Also, even if it is, it's not CrossFit that's doing it. It's probably one or two specific things.
Sure.
Which is that person's job to help try to figure out.
Right. Yeah. I mean, our job is not to take things away from people's lives, help them navigate them better and find a way that they can do them more tolerably. And then hopefully back to the way they were doing them in the first place. So, I mean, there's obviously extraneous situations, right, where it's like, you're never going to be able to do this again kind of thing. If you just completely blow out your knee and you want to do, I don't know, some sort of exercising where you're doing a ton of cutting and lateral movements and stuff like that. Like, it might be tough to get back to that kind of thing. But yeah, we don't need to be on this big witch hunt of like this obviously easy thing to get rid of when it's something that's important to them. So.
Yeah, it's sort of like if they're just spending their careers seeking out like, oh, like this is a CrossFit injury. And then they like every time they see that, they're just sort of creating this. Like if I search, right, case report, CrossFit, carotid artery dissection, you can find it. Case report, chiropractor, carotid artery dissection. Say, aha, see, look how dangerous these things are.
Sure. So
I think people do get these sort of not selection biases, but biases towards activities. And they just say, yeah, people are doing this, they're irresponsible, and I'm doing my part in harm reduction by telling people not to do these.
Yeah.
So I guess speaking of not necessarily good advice from traditional medical field, what are some of the bad advice examples you've seen from either physicians or nurse practitioners or physician assistants that are coming from like that traditional medical background, and you thought, that's their recommendation, but it's not a good one or not necessarily an evidence-based one?
Sure. I mean, number one would be rest. Just prolonged rest from anything. I mean, it's the same thing where you're going to be, that person is most likely to go back to doing whatever it is that you told them to rest from, right? And it's pretty likely that they're going to have that deconditioning and then they're going to run into the same problem again. We just see over and over again the evidence that rest is not the way to go. Your body craves movement. You just need to find a way. There is rest to a certain degree. You have an acute back spasm or something like that, resting for 1 or 2 days can certainly be helpful. But at some point, you need to start moving your body again and getting it more back to being accustomed to going through the normal movements of life, of spinal flexion, of spinal rotation, of whatever these things are. The more that you avoid these things, oftentimes we see that person's pain buffer get larger, and that just leads to more problems down the road. And it's why chronic back pain, not specifically why chronic back pain, but it's a big reason why chronic back pain is such a problem, is because people get so afraid of doing things because they've been told to rest. And I would say the other thing too would be, I mean, it's kind of cliche at this point, but like over prescribing of painkillers to some degree. And I'm not even saying just opioids, although obviously that is a huge problem. But painkillers in general, I don't think anyone's answer to a problem should just be just take a painkiller of some sort always. There are situations where I tell my patients, I'm like, it's a great idea. Like, you're about to go to work and you need some sort of quick pain relief to help you through your day. Going to the chiropractor is going to take longer than you taking Tylenol and getting a little pain relief before you go. And that is just fine. Like, you can do that. But where I see the problem is it's almost like this repeated advice over and over and over again, because it worked to some degree, and maybe the doctor's rushed, maybe the doctor just, that's good enough for them. And it creates this narrative in the person's head that is what they should do each time that this comes up. And before you know it, they've built up some sort of tolerance to that, and they either have to increase that or they have to find other ways. Thankfully, sometimes finding other ways turns into them going to a conservative musculoskeletal care clinic. But those would easily be the top two most common advice that I would disagree with from an MD or whoever when it comes to prescribing what to do when you have some sort of musculoskeletal injury.
Yeah, it kind of seems like rest is an easy thing to say if you don't have specifics to tell them.
Sure.
A lot of times people feel like they have to say something other than, let me send you on to this other specialist or healthcare practitioner. You mentioned that you do frequent a CrossFit gym from time to time.
Yeah.
When it comes to your diet, exercise, sleep, whatever other lifestyle things that you do, for those that are curious, what do you usually implement?
I would consider someone who's pretty darn in tune with my diet. I'm like flexible paleo, and there's some degree of why that is in my past and things like that. It's just a diet that I found that makes me feel the best. I am not hardcore paleo, keto, carnivore, whatever. I'm not hardcore any of that kind of thing. I think that can actually be dangerous. But I like being in that realm because it forces me to increase my protein intake to the degree that I think is right, which for me, I do 1 gram of protein per pound of body weight. I don't remember what your guys' recommendation. I'm trying to remember off the top of my head, but somewhere around
That's
there.
good. Yeah.
And why I say I'm flexible is I eat like a lot of rice, and I'll like eat quinoa and things like that, because I find that for someone who's doing that much output myself, carbs are a much better fuel source for me than trying to go like a keto and utilizing fat as that. And to me, I think if you're a person that's putting that much output, I would say the same. I'm pretty convicted on that.
By output, do you mean cardio, regardless of intensity?
That's a good question. I guess if you're someone who's just doing like low level cardio where you're 20-minute walks 5 times a week or something like that, maybe not so important. But if you're doing moderate to high intensity exercise, weightlifting, especially if you're doing like a CrossFit or a High Rocks or something like that, where it's basically a mix of high intensity exercise and weightlifting, I think carbohydrates are going to be a better fuel source for you than fat. And I do get concerned sometimes when I see people in that realm get really into carnivore or something like that, where I'm not sure how your body's going to keep up from a long-term standpoint. I'm willing to be wrong on that. I'm kind of interested if I am. But in terms of that too, I try to decrease my liquid calories as much as possible as well. I just feel like I don't run as well, honestly, both literally running and just run as a person too. When I have an increase in liquid calories, I don't feel like I have as much energy. I feel like my workouts are horrible, and I feel like I don't recover as quickly from my workouts when that happens. So maybe there's just something to chewing your food. I don't know, but those are some of the tenets for me that I tend to stick with when it comes to trying to keep my body in shape in terms from a diet standpoint. In terms of sleep, I just try to get 8 hours as much as possible. I do try to decrease my screen time. I have good seasons and bad seasons. March Madness is a horrible season for that. It's coming, so I'll have to be careful. But yeah, diet, sleep. And then I have spiritual practices. I am a man of faith. I'm a Christian. I every single morning spend 30 minutes in the Word and in prayer and things like that. And those things I do think have a significant impact on my health. And honestly, to add on it, I guess I'm rambling a little bit, but I do have a good community around me. I think that piece is really important too, and is one that is really underestimated.
Definitely.
And so I guess I'm just kind of expounding on what I guess my tenets are that have become natural over the years, but those are like community, the spiritual practices, my diet, my sleep. Those are 4 massive pillars for me in my life that are pretty non-negotiable.
Yeah. Now that's an excellent list. Pretty similar to our list too. Do you have a specific way or do you often give general advice on how people can improve their diet and sleep and social health and things like that as well?
And if I'm wrong, I want to hear it. I'm up for it. I typically tell people I do try to get a baseline of where is your protein intake. So I am finding, wow, so many people do not eat that much protein. I'm shocked by it. I had a woman the other week who basically her protein is a third of a cup of cottage cheese, and that's it. Like every day. I don't know. It's like 18 grams of protein. I don't know, something like that.
Yeah.
I don't care how much you weigh. You need more than that.
Yep.
And so that's usually one big piece that I hit is what your protein intake too is. I do recommend that people decrease liquid calories if it's something that's a significant part of their life. You know, whether that's soda or juice or whatever it may be. I that's more anecdotally in my life why I recommend that. So, you know, maybe there's quite a bit of bias that goes on there, but it is something that I typically recommend to people. And then two, I do try to get an idea of what their sugar intake is. And if it's really, really high, especially processed sugars, obviously, I don't really have a problem with fruit or anything like that. But if it's pretty high, I usually try to get people to decrease that because in my world, inflammation does play a part into your recovery and musculoskeletal injuries. And if you're, you know, chomping away on hundreds and hundreds of grams of processed sugar, your inflammation levels are very likely to be higher unless you're doing, you know, CrossFit 7 days a week, 2 times a day, then the sugars are probably just fueling you. But
yeah. So before you built your way out of this, where you're in this paleo era, what was your liquid calorie that was a problem for you?
I used to be a soda drinker. I was a big Coca-Cola guy, just straight Coca-Cola, especially from McDonald's. That McDonald's Coke hits different. I don't know if you guys have experienced that.
Interesting.
I was a big Gatorade guy. I don't know. Just, I didn't like regular water, I guess. And that just kind of flipped at some point. And now, you know, it's just, I didn't realize how much of it I was really intaking.
Yeah.
You know, I couldn't necessarily put a number on it, but it was at least hundreds of calories, you know, multiple hundreds of calories a day. And this is a long time ago. I mean, a long time ago, but,
couple weeks
ago. Yeah.
Yeah.
These last 3 weeks have been amazing. So
it's a tip if people like bottled water, but they dislike the microplastics in there.
Sure.
We got a zero water. It's a carbon water filter.
Okay.
They're pretty cheap, but it makes your water you drink out of a glass taste like bottled water. So for me, like I'd always found bottled water just tastes better than tap water.
Sure.
Just a personal preference. And for me, that really helped increase my fluid intake, just making sure that I'm, like, especially in the morning, getting enough hydration in. Because if people are not drinking a significant amount of water in the morning, you're probably operating like, I don't know, 80% capacity the whole day.
Sure.
So it can make a big difference.
Sure. Yeah. And it did increase my general water intake too. I just realized how little I was drinking water too. So that was obviously a positive effect. Did you guys watch Super Bowl last night?
We watched the first half.
You gave up. There was a commercial for some sort of water company. I can't remember who it was. It's like
hopefully
Liquid
not.
Death. Yeah.
Oh yeah.
They still use plastic liners in their aluminum cans. You have to have a plastic liner in there. Your water's going to taste like aluminum. But they have had the mantra of like death to plastic, and that's like what they're all about.
Yeah,
So
really
I
interesting
tell people
branding.
that are drinking it, and they're like, I'm like, hey, you know, there's still plastic in that, right?
Yeah.
And they're like, no. So I mean, they're making money.
Yeah, doing it.
Well, you're a great source of information and knowledge. We'll obviously link all of your websites and social media and whatnot.
Sure.
But for where people can find you, where's your like main base of operations? Where should I look?
If you want to find me online, my Instagram is probably the best one, at Bergner Chiro, BergnerChiro. If you are local to Kansas City, my practice is located right off 35 Highway and Shawnee Mission Parkway. If you know like the new Grand Station lofts and stuff like that, I'm right over there by all those areas. So I'm there 5 days a week, sometimes 6 as an entrepreneur, sometimes 7. So yeah, you could definitely find me there if you're interested in getting some help or just having some questions answered. I'm happy to help in any way that I can. But those are definitely the 2 main ways to get to me. So
wonderful.
Yeah.
Well, we appreciate it.
Yeah.
All of the listeners, please put your nice, mean, and in between comments down below, whether it's YouTube or Instagram. We'll post it on everything. And as always, thank you for your time listening, and may God bless you with health and happiness.